Good evening, everyone. I'm Dr. Sarah Mustafa from DentistChannel.Online. Welcome to today's webinar about the basics of root coverage procedures in periodontology. While we are waiting for the participants to join the session, I will introduce you to our company. DentistChannel.Online is a digital dental media company. It is your marketing solution for dental events, product launches, workshops, and courses. We also provide a collection of scientific articles and blogs about different topics in dentistry. We work hard to be your first-hand information on the technological advancements in the dental field. Now it's time to start the session about the basics of root coverage procedures in periodontology. If you have any question about this topic, please feel free to ask it in the question and answer box, and we will answer each and every question at the end of the session. I will start by introducing today's session speaker, Dr. Aisha Hanif. Dr. Aisha completed BDS from Dow University of Health Sciences, Karachi, Pakistan in 2011. She started off as a lecturer in the Department of Prosthodontics. 3 years later, she did masters in the field of periodontology, and she is awaiting the thesis defense in the same subject. She is also pursuing MSc in clinical education from the University of Edinburgh. Welcome, Dr. Aisha. It's our pleasure to have you with us.
Thank you so much, Dr. Sarah, for such a wonderful introduction of mine and your channel. And it's a pleasure to be hosting this webinar with you today.
The pleasure is ours, Doctor.
So should I start off?
Yes, please.
Okay. Good evening, everyone, or good morning, wherever your time zone fits you. Today, we will be talking about the basics of root coverage procedures in periodontology. When I talk about basics, I am looking forward to equip the general dentists, the fresh graduates, and the final year students about these are the topics that we are going to cover. So you all need to have the basic idea how to diagnose, how to know about the etiology of gingival recession, and how to at least know how to manage a gingival recession. This is the lecture outline. We will start off with a gingival recession, the anatomic considerations, and the etiology of gingival recession. So what is recession actually? It is basically the apical migration of the gingiva from the cemento-enamel junction. If you see this picture, let me just open up my pointer. So if we identify this is the cemento-enamel junction and this is the marginal gingiva that has gone below. If you see the side with the tooth adjacent to it, the cemento-enamel junction is not visible, which usually is the case in the healthy gingiva. So whenever the marginal gingiva is going below the cemento-enamel junction, that is known as gingival recession. There is another term which is known as periodontal recession, which is a new term that has been introduced because when we talk about recession, it's not just the gingiva that is going down, it's also the other supporting structures of the tooth as well, which are the accompanying periodontal fibers and the underlying bone. But for this lecture, we will be using the term gingival recession as it is. Before going ahead, let's just revise a bit of anatomy for our sake so that we can understand what we will be talking about on the next slides. So the important things to consider here are the attached gingiva and mucogingival junction and the alveolar mucosa. Let's start off with this. This is your marginal gingiva. This is the interdental gingiva. This is your keratinized gingiva, which has both the free gingiva and the attached gingiva. Then you have a mucogingival junction. Sorry for that. And you have a mucogingival junction, beyond which begins your alveolar mucosa. If you see the schematic diagram, the cross-sectional diagram on your right-hand side of the screen, it is showing the gingival margin, the free gingival groove, and the attached gingiva. The mucogingival junction separates the attached gingiva from the alveolar mucosa. A very important concept when we talk about the anatomical considerations is the concept of gingival biotype. You need to assess how thick is your biotype, because this has a lot of consequences and implications when we talk about gingival recession. So there are basically two methods of identifying gingival biotype. The first is the visual method, in which you introduce your periodontal probe inside the sulcus and then you just visualize. If the probe is not visible when you insert it into the sulcus, then you call the biotype as thick biotype. Whereas if you insert the probe inside the sulcus and you can see the probe shine through the gingiva, then your biotype is thin biotype. Another method of assessing the gingival biotype is using the endodontic reamer, but in this case, you have to anesthetize the area and you introduce an endodontic file inside the gingiva till it touches the underlying bone. You use the stopper and you take the stopper till the gingival till it touches the gingiva. Then you take it out and you measure it either with a scale or vernier caliper. If the measurement is more than 1 mm, we call it thick biotype. And if the measurement is less than 1 mm, then we classify it as thin biotype. How important is knowing biotype is, we'll see in the coming slides. So when we talk about the gingival biotype, we have now seen that it's either thin or thick. This picture is denoting a thick biotype, and this picture is denoting a thin biotype. So the shape of the teeth is going to be your first clue that is going to tell you which biotype your patient is presenting with. It's not necessary that the entire mouth will have the same biotype. It's very normal to have both type of biotypes are varying according to the tooth site. So mostly you will see thin biotype in the mandibular incisors and around the canines and premolars, and there is a chance that the rest of the mouth has thick biotype. What are the implications of having thin biotype? The first and foremost thing that affects us is that thin biotype is more prone to gingival recession, whereas thick flat biotype, what it does not go to recession directly, but it reacts to disease with the pocket formation. Also, with the thin scallop biotype, we have a very narrow zone of keratinized tissue, whereas with the thick flat biotype, we have a wide zone of keratinized tissue. We will see how having keratinized tissue is going to affect the recession. The thin biotype usually presents with a nice scalloped architecture of the gingiva, whereas a thick biotype is usually dense and fibrotic, and it is usually flat as compared to the thin biotype. So these are the differences. Now we know about a gingival biotype as well. Let's see ahead. To be treating any disease, you first of all need to know the etiology of that particular condition. When you know the etiology, only then you're going to be able to make a good treatment plan that actually helps in treating the condition. The main etiological factors of gingival recession is plaque-induced periodontal inflammation and a mechanical trauma. These two are the factors which actually contribute to gingival recession directly. However, there are other predisposing and precipitating factors as well, which implicate in the etiology of gingival recession. Now, what do we mean by predisposing and precipitating factors? All the factors which increase the risk of a person having that condition are the predisposing factors. And the precipitating factors are those, if they are present, they will enhance the severity of that particular condition. So it's not just etiology of gingival recession is not one way. It is multifactorial, and it has direct and indirect causes as well. So when we talk about the predisposing factors and the precipitating factors, we have to see them. The predisposing factors are the risk factors. So the bone dehiscence, the fenestration defects, the dimensions of the gingiva, and the aberrant frenum. If these are present, the presence of these three are the predisposing factors which increase the risk of a person towards more gingival recession. When a person presents with thin gingival biotype, there is inevitably chance that you will be noticing more of bone dehiscences underneath the thin gingiva. Dimensions of gingiva, when we talked about gingival biotype, this is why it is very important to know the dimensions of gingiva and why it is important. With the thin gingiva, there is inevitably more gingival recession. And then there is aberrant frenum. If the frenum is attached to coronally towards the gingival margin, it is inevitably going to pull it towards itself, which leads to more gingival recession. Then there are certain precipitating factors. If these factors are present in the presence of these predisposing factors, all these factors can enhance the severity of that condition. They include toothbrushing trauma, oral piercings, subgingival restorations, deep traumatic overbite, self-inflicted injuries, orthodontic therapy, herpes simplex virus infections, and smoking. Now let's have a look at all of the etiologies leading to gingival recession and how do they contribute to it. So if you see the figure first figure is showing how recession is happening because of periodontal inflammation, because of the calculus accumulation that is there. In 1B, there's also periodontal inflammation going on. However, the patient is a smoker. Having this, smoking is becoming the precipitating factor. This one is because of the traumatic occlusion. This one is because of the prominent roots. The tooth positioning is out of the arch. This one is interesting if you see the tobacco dipping. In our part of the world, especially in subcontinent, this is very common. Locally, it is also known as when the person is taking naswar. That is when you see localized gingival recession occurring at the point where the person is habitually keeping naswar. This is self-inflicted because of the parafunctional habits of the patient. If the person is constantly in a habit of nail biting or pen biting, the trauma can occur which can lead to gingival recession. This one is because of the periodontal inflammation, and this one, if you see here, is because of the aberrant attachment of the frenum. So this is the case. Let's see what were the etiology. Like I said, the etiology of gingival recession is not single way, it's multifactorial. So in this case, if you notice, there are several factors that led to the recession of this particular tooth. First and foremost, obviously the buccal positioning of the central incisor, what it did, it basically, there was no cortical bone surrounding the root of the tooth. There was no overlying gingiva over it, and any trauma would lead to recession. Then the thin gingival biotype. Again, the gingival biotype plays a very important role in determining the occurrence and severity of gingival recession. Moreover, this periodontal inflammation that is going on inevitably. Once the keratinized gingiva has been reduced, one gingival recession causes this type of recession defect. What it does is that it hinders the patient's ability to keep the tooth clean. You need to have a certain vestibular depth for the toothbrush to be kept in a particular way so that the cleaning can happen. In this condition, what was happening, the patient was not able to keep the teeth clean, and it was leading to accumulation of plaque and calculus, which was leading to more periodontal inflammation. So you see, etiology of recession is never a single folded. It is always combined with its predisposing factors as well as its precipitating factors. What happens when a patient does have root recession? So your patient will complain of dentinal hypersensitivity. You might notice, or the patient might notice, root caries. Then there is non-carious cervical lesions, the abrasions, difficulty in maintaining oral hygiene, like I explained in the previous picture. There is compromised aesthetics, obviously, and you need to see with all these sequelae that the root recession can cause. Not all the cases of recession defect demand you to manage them surgically. You will have to identify if you want to do that. So if you want to perform the surgical treatment of that patient and how beneficial it is going to be for the patient. We will see how would you select your patient accordingly. All right. Before going ahead, let's just have a quick look at the classification of gingival recession. This is important. I have introduced why do we need a classification system? You need classification system so that you can identify and you can categorize your defects into classes so that you can reach to a treatment plan accordingly. Moreover, if you want to have an opinion of your fellows, or if you want to tell it to other people, you have to have a unified system that is accepted across the board so that your message goes across evenly. Moreover, you need a recession classification system because how else would you check your pre and post results of any surgical treatment plan? That is why it's very important in clinical trials as well, in studies as well as clinical settings. I have talked about two classification systems. The first one is the Miller, which has been here for 2 decades almost. This was the widely used classification system. It's still used at some places. This was a system that was introduced in 1985. They described 4 classes of recession, and they had taken the depth of recession in relation to the mucogingival junction and the level of interdental support. So let's have a look at what does class 1 say. In class 1 and class 2, there is no loss of interdental tissue. Bone or soft tissue, there is no loss of interdental tissue. However, in class 1, the recession defect is not reaching towards the mucogingival junction. And in class 2, the recession defect is either reaching to or beyond the mucogingival junction. In both of these cases, complete root coverage is possible. In class 3, there is interdental bone loss with soft tissue loss in the interdental area. There is certain malpositioning of the teeth as well. Partial root coverage can be achieved. In class 4, the gingival recession extends to or beyond the mucogingival junction with severe bone loss and soft tissue loss in the interdental area, and there is severe tooth malpositioning. In theory, no root coverage can be expected. This classification system was widely used and it stayed for 2 decades almost. However, recently, Pini Prato et al., they identified certain inadequacies with this classification system, and then we had newer classification system coming in. For instance, if you see, there is a certain amount of keratinized tissue anyway apical to the recession. So there is no way that a recession is going to extend beyond the mucogingival line. Or if you see, there is no exact criteria. How do you identify the malpositioning? For instance, if there is malpositioning present, for one practitioner, it would be mild. For another, it would be severe. So that's becoming more subjective rather than having a pure quantification of the malpositioning of the teeth. So there were many inadequacies identified, and then then another classification system came in. The famous 2017 workshop on the classification of periodontal and peri-implant diseases, they presented a new classification system for the gingival recession. What they did, they classified the gingival recession based on the interproximal clinical attachment loss, the gingival phenotype, and the characteristics of exposed root surface. They classified it in the recession in 3 classes, and they named them recession type 1, recession type 2, and recession type 3. In recession type 2, there is no loss of interproximal attachment. Whereas in recession type 2, the loss of interproximal attachment is less than or equal to the buccal attachment loss. In recession type 3, the loss of interproximal attachment is higher than the buccal attachment loss. When we talk about gingival phenotype, it actually takes into consideration the gingival phenotype as well, which is essentially the gingival biotype. We saw how important that is. Along with it takes the characteristics of the exposed root surface. So basically, when the recession happens, what happens is that most of the times you lose the site of cemento-enamel junction as well. And then in certain cases, there are cervical lesions, abrasions present, and in certain cases, there aren't. So this classification takes all these 3 things in comprehension and then classifies a particular recession defect accordingly. Now that we've revised about the anatomy, the etiology, and the classification systems, let's see how do we examine and diagnose the recession defects. When we talk about the periodontal examination, obviously the first thing is to measure the recession defect. The recession is measured from the cemento-enamel junction to the crest of the marginal gingiva. The distance between these two reference points is going to tell you how much recession is there. If, for instance, if we consider this picture, it's 1, 2, 3, 4, and 5. So in this picture, you're seeing 5 mm of gingival recession that has happened. The second thing to examine in the periodontal examination is the periodontal probing depth. It's the distance from the crest of the marginal gingiva to the base of the sulcus. You're obviously not going to see the probe outside, it's inside, and then you're going to measure how much the depth is. That gives you the probing depth. So this distance is telling you the probing depth, whereas this distance is telling you the recession. Another thing to measure is the keratinized gingiva. Now, how do you measure keratinized gingiva? There are two methods for it. One is called roll method, and the other one is called the Lugol iodine solution method. What you do is you just take your probe and you actually do roll it around the mucogingival junction towards the crest of the marginal gingiva. You will see at one point that when you're rolling your probe along, the point where your mucosa does not move at all, that is you measure from there, and that is going to tell you how much keratinized gingiva is present in that particular case. Another method is to just simply apply this Lugol iodine solution. It is going to stain your the alveolar mucosa in dark brown color because of the presence of glycogen, whereas the attached gingiva stays unstained. So these are the two methods with which you identify keratinized gingiva. And again, very important, I am coming back to it, I think the fourth time, that you have to measure the gingival thickness. The gingival biotype is very important. This procedure is also known as transgingival probing. After the periodontal examination, another important part in diagnosis and the examination of these defects is the radiographic examination. So there are different types of radiographs which are available: periapical, bite wing, OPG, and CBCT. You order a periapical when you have to identify the crown root ratio. A bite wing is important when you have to identify the interdental bone levels. You get an OPG done when you have to look at the overall presentation of the disease of the particular patient. CBCT gives you a really good idea of the underlying osseous defects, etc. However, it is not recommended in every case, but CBCT is also a very good new innovative tool. What we're trying to see here is the crown root ratio, the furcation involvements, the periodontal space, the crestal bone level. All of these are going to tell us what is happening inside the patient's mouth and what could be the etiology leading to it, and how do you actually get to the treatment plan. All right then. So I'll be briefly talking about the recession coverage techniques. First and foremost, I will be starting off with the soft tissue augmentation. We will talk about soft tissue grafts, the substitutes of the soft tissues, and why actually do we do soft tissue augmentation in this recession defects. Okay, starting off with the soft tissue grafts, which are the autografts. Autografts are the grafts which are taken from the same patient. They are either free gingival graft, the connective tissue graft, and the pedicle graft. Let's have a look at these one by one. Free gingival graft, it's the most commonly used graft. It has epithelium along with the underlying connective tissue. It's called free because it is separated from its donor site, and then it is taken from that donor site and sutured to the recipient site. So the connection between the donor site and the recipient site is not the same. That is why it's called free. It can be harvested from hard pellet. Usually the dimensions to harvest it are from the distal of the canine to the mesial of the second molar. You have to be aware of the underlying anatomy, underlying blood vessels, etc. so that you can harvest your graft accordingly. And another area where you can harvest it from is the maxillary tuberosity. If you see the pictures here, this is one of the cases in which the free gingival graft was harvested from the patient's palate. And this is how it looks like, with the epithelial covering the underlying connective tissue. Obviously, with every autograft and every substitute that we will be seeing, there are certain advantages and disadvantages. The advantages of free gingival graft are it's most commonly used, it's technique insensitive, it is really easy to harvest. When you have to increase the width of the keratinized gingiva, this is the preferred graft that you take. Also, when the patient presents with thin gingival biotype, again, this is the preferred graft that you take. Disadvantages include, if I go back to this slide, so imagine the whole of the graft has been taken from here. So obviously, this graft is going to heal with secondary intention. In theory, it does lead to more patient morbidity and pain threshold. However, clinically, the pain threshold can be controlled. The pain and post-op morbidity can be controlled. It's not that bad, but obviously it does lead to an additional surgical site and increased patient morbidity. Patients do feel a lot of discomfort while eating, while chewing. However, there are methods to manage that as well. But in theory, it is still the technique that increases patient's morbidity. Another disadvantage is the anesthetic blend of the tissue. When you have to do the grafting in the aesthetic zones, you usually avoid the free gingival graft, because what happens is that it heals with a distinct color and texture of the gingiva. It's very prominent even after healing. So it gives a bit of anesthetic look when it heals. Also, there is a chance that, free gingival graft over a larger area of exposed root will not be able to get blood supply, adequate blood supply. And there is a chance that the graft gets necrosed. Coming to connective tissue graft, the CTG. This is the graft which is without the overlying epithelium. It is also harvested from the hard palate and the maxillary tuberosity. If you see the pictures here, this has been harvested from the palatal area as well. However, the epithelium was lifted and it was not taken off. It's kept intact. The underlying connective tissue has been harvested here, and the overlying epithelium has been sutured, and now the area is going to heal with primary intention. Looking at the advantages and the disadvantages of the CTG, the advantages are primary intention healing of the donor site. So there is obviously less morbidity for the patient. It gives very predictable results. It has long-term stability, and it has good aesthetic results as well. All these factors were not available with FGG. Whenever you have to increase the thickness of the tissue and whenever you are eyeing the full root coverage, this is the graft that we go for. What are the disadvantages? The first and foremost disadvantage of this technique is that it is very technique sensitive. You have to have control and you have to have experience in harvesting connective tissue graft from underneath the overlying epithelium. Then you have to be careful that you have to leave enough epithelium and enough connective tissue so that when the graft is healing, the donor site is healing with primary intention, it does not get necrosed. There are at times when after the extraction of the connective tissue graft from the donor site might lead to dehiscence of the donor site. But these are the disadvantages which will you overcome with time, with experience, and with technique. Theoretically, they sound very horrible, but clinically, it's not that horrible. And then the third is the pedicle graft. Why do we call it a pedicle graft? Because you are not, in both the CTG and the free gingival graft, you were removing it from the donor site and then you were taking it towards the recipient site. However, in the pedicle graft, you're not separating it from the donor site. The graft has its attachment towards the donor site and then it is shifted towards the recipient site. If you see this example, this is the recession that has to be treated. This graft has been taken from the adjacent tooth and it is just turned over towards the side that needs root coverage. So this is the pedicle graft. The advantages are the first and the foremost advantage, and that is very much needed in every graft that we do, is the blood supply. When you're not removing it from the donor side, you're preserving the blood supply. There is harmonious color match because the same gingival tissue has been transferred to the other side, and obviously there is no second surgical site morbidity. The disadvantages, however, is it's very technique sensitive, and it can only do single tooth recessions where there are minor shallow recessions. Those are the only conditions in which you can go for pedicle graft. In conditions where you have narrow oral vestibules or thin biotypes, these are contraindicated. So with advancements, what has happened that patients' acceptability towards the procedure, patients' concerns about the second surgical site morbidity have led to the development of soft tissue substitutes. These help us in having a material which is a substitute and does not lead to second surgical site. It eventually leads to more patient acceptance of the procedure. So we have either Allograft, which is acellular dermal matrix. It is obtained from the donated human skin. And then an Allograft is a graft which is obtained from the same species but different individual. And then we have Xenograft, which is obtained from a completely different species. In these cases, they are xenogenic collagen matrices, which are porcine derived. So if you see, this is the example of the Alloderm, which is the Allograft, and this is the mucograft, which is obtained from a porcine derived source. Both of the grafts are treated. All the viable cells are removed, which could lead to immunogenic responses or inflammatory responses. Then the remaining connective tissue matrix provides a collagen structure that functions as a scaffold to allow ingrowth and subsequent replacement by host tissues. So basically, the soft tissue substitutes have also been studied upon. They have given really good results, and in literature shows that the result of the autograft is comparable to the usage of Allograft and Xenograft. However, as amazing as they sound, they also come with their share of advantages and their share of disadvantages. The advantages, obviously, there is no second surgical site, there is reduced morbidity, there is unlimited tissue availability. Obviously, if you're harvesting a graft from palate, there is only a certain amount that you can harvest. If you have to harvest more tissue, you will be subjecting the patient to two surgical sites, two sides of the palate to harvest more graft. This is not the case in substitutes. There is reduced surgery time, and obviously the patient's acceptance to the treatment has increased. However, the disadvantages are its limited availability across the globe. In modern states, in first world countries, this is available readily. However, in certain parts of the world, this is still unavailable, and it's expensive. So it leads to higher cost of the treatment. Once you've identified everything, now we also know what we have to use for soft tissue augmentation. Why do we actually do soft tissue augmentation? The general common perception is that wherever there is root recession, there has to be complete root coverage. However, there are other indications as well. Why do we perform soft tissue augmentation? The first and foremost, obviously, you will be eyeing for complete root coverage. You do soft tissue augmentation to increase keratinized gingiva. See, the amount of keratinized gingiva is very important in maintaining the health of the remaining teeth. This is a good example of the procedure. If you compare this picture, the first picture with the last one, you do not see complete root coverage. However, what you see here is increased zone of keratinized gingiva. The cycle of periodontal destruction in this case has been reversed. The patient will be able to clean well, maintain the oral hygiene, And with the increased amount of keratinized gingiva, the bacteria and plaque accumulation do not lead to that much destruction as thin gingiva and less zone of keratinized gingiva do. And in certain cases, you want to harmonize the gingival zenith. Those are also the indications why we perform soft tissue augmentation. Okay, so I'm going to show you one of my cases in which soft tissue augmentation was done, not for root coverage, but to modify keratinized gingiva. This was the initial picture. If you see here, if you notice, there is hardly any keratinized gingiva left underneath these teeth. There is hardly any keratinized gingiva left. What we did, so in this case, I'll show you the radiograph in a moment as well. So in this case, the patient was concerned about the losing, the deteriorating condition of his teeth. He did not want to get them out. He was very willing, he was educated enough, and he wanted to get the treatment done himself. These are also very important factors when you're considering periodontal surgery, because if your patient is not motivated or your patient doesn't understand the concerns, however good surgery you do, you're not getting the results because your patient was never on, you and your patient were never on the same page. This is the radiograph of the same case. You see there is extensive bone loss. We've hardly remaining less than 25% of the bone in these two teeth. The teeth were mobile. We told the patient that in this case, we cannot achieve root coverage. One of the important factors of achieving root coverage, if you remember RT3 or Miller's class 4 classification, was interdental hard and soft tissue loss. We have immense hard and soft tissue loss here. So we told the patient that complete root coverage was out of the questions. But what we could do here was modify the keratinized gingiva so as to give more years to these teeth. And maybe in future, a second surgery would have been possible. But with the amount of bone destruction that this shows, a complete root coverage in any case wasn't possible. So a recipient bed was prepared. With the help of the periodontal probe, the site was measured, and the same amount of the site is being again measured at the donor site. The amount of the FGG, free gingival graft, was taken, and this is the picture right after suturing. This is the picture 3 days after surgery, and this is the picture 2 weeks after the surgery. So again, if you appreciate, there is no root coverage, but there is considerable modification of the keratinized gingiva. This is one of the major indication of soft tissue augmentation. Now that we know the grafts and everything, how do we actually make, if we have to perform a surgical procedure in a particular case or not? See, not all recession defects require surgical interventions. There are certain factors which will tell you if you need to really go for the surgical management or not. First and foremost, patient's concerns. The patient is going to come with the concern of sensitivity. He'll come with the fear of tooth loss, aesthetic concerns, and obviously difficulty in maintaining oral hygiene. If these are the concerns, then yes, it's an indication for periodontal surgery. You have to take in consideration the patient's systemic statuses and habits as well. If your patient is active smoker or takes alcohol intake or takes tobacco intake in any form, that patient is a contraindication for your periodontal surgery. Certain systemic conditions affect periodontal tissues directly. For instance, diabetes. If the patient has uncontrolled diabetes, you would want to not go for periodontal surgery. Then there is if active periodontitis is there and patient's attitude towards oral hygiene. These are the factors which actually determine if any treatment that you've taken is going to be fruitful or not. Then operator's judgment and ability. How able are you? How experienced are you in doing these surgeries? If you're not, referral is always the option. But you will be able to refer it only when you know the basics, when you have identified the etiology, when you have examined and diagnosed the recession properly, and when you know this particular patient needs surgical intervention. Only then you will be able to make a good referral. The point of this presentation today is actually the same. With all this knowledge in comprehension, in totality, is going to make you able to refer the patient to the specialist. So generally, you will only do a periodontal surgery if you have patient's concerns or if there is active recession going on. If your patient has concern, if the active recession is going on, yes, that is the indication of periodontal surgery. If your patient needs restorative or orthodontic needs, if you need to modify any of the predisposing morphological factors, then you will consider a periodontal plastic procedure. However, if your patient needs a restorative or orthodontic need, if they don't need a restorative or orthodontic, then you don't have to really intervene and you don't have to do surgery. You just monitor the recession, you identify the predisposing factors, you modify them, and you educate the patient on them and see if in the long term the recession progresses or not. We have seen in the etiology that recession is multifactorial. So even if you see there is one or two of the predisposing factors are present, but there are no precipitating factors, or the precipitating factors are present, but there are no predisposing factors, there is no effective way yet to predict the occurrence of gingival recession, which means a preventive procedure is generally not recommended. You have to identify the predisposing factors and the precipitating factors, the patient's attitude towards the treatment, and your own expertise, and only then you make an informed decision if you have to go through with it or not. Even if you decide that you have this particular patient has to undergo periodontal surgery, if you do not control the precipitating factors and the predisposing factors, there is no way your treatment is going to be fruitful. So now let's have an overview on the selection of the root coverage technique. How do you make the decision? I will not be talking too much about the different techniques of the root coverage itself, because that is another domain in its whole. We were keeping this lecture very simple. So I will just be giving you an overview of the decision making. Whichever technique you want to go for, these are the 4 things that actually are going to tell you which procedure is better for that particular patient. The depth of the recession, the amount of keratinized tissue, apical or lateral to the recession, gingival biotype, and your skill and experience. Since I have not talked in detail about the recession techniques, this is just an overview, a really good decision tree that is going to help you. So like I said, everything starts from identifying the etiology of gingival recession. If you've identified wrong etiology and you're giving a treatment plan with the etiology not being taken care of, your treatment is not going to work. Remove the etiology, check the recession defect. The techniques become different for single recession, 1 or 2 tooth recession, compared to multiple recession defects. Again, you identify the interproximal bone loss, and then you can tell your patient if there is no interproximal bone loss, which was the Miller class 1 and 2, or a Cairo R1 or the 2017 RT1, then you can tell the patient, and then you know as well complete root coverage is possible. But even in this case, the next thing to identify is the amount of keratinized tissue. If the keratinized tissue is adequate, we say 2 mm of keratinized tissue has to be there for the maintenance of the periodontal health. If there is adequate keratinized tissue and there is thin biotype, you go for coronally advanced flap along with connective tissue graft or the connective tissue substitute. I have not discussed in detail these techniques because this is beyond the domain of this lecture. The other would be the subepithelial technique and the connective tissue graft. The point is, you need to identify all these predisposing factors first. These are the factors that decide your technique. If there is no interproximal bone loss and there is inadequate keratinized gingiva, then again, you identify the biotype first, and then according to that, you select the proper and appropriate root coverage technique. So I guess that's it. These were the basics that I wanted to cover. I hope it was fruitful. If there are any questions, I'm ready to answer them.
Thank you, Dr. Aisha, for this informative session. It was a very nice presentation. So meanwhile, I'll ask your permission to introduce our company to all the participants, and I request all the participants to kindly put their questions in the question and answer box. So this is our organization, DentistChannel.Online, Healthy Smiles, Wealthy Lives. DentistChannel.Online is India's first digital dental media company. We did webinars with more than 400 national and international speakers, many successful word implant expos, more than 700 live dental webinars, and 20 online workshops, and much more. If you're not a Prime member yet, kindly join our family to get free certificate of participation after every event and get exclusive offers and discounts on our online and on-site paid workshops and courses. Prime members will be awarded with 1 CPD CE point for each free webinar. You can use my promo code SAR100 to benefit from a discount. So the Prime membership will cost you around $9 per year. This is an example of the certificate of participation that you will get after every event. About our upcoming webinars, we have 2 webinars tomorrow, one with Dr. Daniel about laser dentistry in daily dental practice at 5 p.m. Indian Standard Time, and another one with Dr. Verma about infection control in dental clinics at 7 p.m. Indian Standard Time. We have another session tomorrow with Dr. Naval about hair transplant surgery. On March 18, we have a session with Dr. Noor about medical emergencies in dentistry at 5 p.m. Indian Standard Time. We have a master class tomorrow with Dr. Ankit about the art of interpreting the different shades of gray. I request all the participants to kindly save this number and then send a message on WhatsApp with their name, so they will be added to our broadcast list and they will receive everything about our upcoming dental webinars and courses. Today's webinar is sponsored by NovaMind. NovaMind offers a full spectrum of implants and prosthetic solutions that accommodate any clinical need in modern implantology. We successfully supply highly demanded dental implants types called internal hex, tissue level, bone level, and active conical connection. Our EU production unit and product quality is appreciated worldwide. Dental implants and dental restorative solutions produced maintaining all the standards of EU medical device regulatory. Products are manufactured in Athens, Greece, and distributed worldwide with more than 1 million happy restorations. If you want to know more about NovaMind, kindly check their website. Finally, don't forget to follow us on our social media platforms, Facebook, Instagram, and YouTube. Now it's time to move on to the question and answer session. We have a question. What is the role of keratinized epithelium in recession?
Sorry,
Doctor, can you hear me?
Yeah, I had muted my mic and I forgot. Okay, I heard the question, the role of keratinized tissue in recession. So literature suggests that you have to have adequate amount of keratinized tissue, which is around 2 mm around the teeth and the implants as well, for the health of periodontal tissue. Keratinized tissue has more ability to withstand the traumatic forces and the influx of bacterial ingress, which happens as the periodontal inflammation progresses. So if you have keratinized tissue, that gives a better defense mechanism against the traumatic and periodontal inflammation compared to the situations when you don't have keratinized tissue adequate of it. Moreover, having keratinized tissue also helps in maintaining the oral hygiene. You need to have a certain amount for you to be able to clean the area. If you do not have keratinized tissue, the plaque and calculus keep on accommodating there, which becomes a vicious cycle, and the inflammation keeps on going ahead.
Okay, doctor, I think that's it. We had a question about the certificate. So I have to mention that all the certificate of participation will be sent only to Prime members. So if you're not a Prime member yet, kindly join our family. Thank you so much, Dr. Aisha, for this informative session. It was a pleasure having you.
Thank you for having me. It was my pleasure to deliver this lecture on your platform.
Thank you, Doctor. We are looking forward to organizing more webinars with you in the future, inshallah.
Inshallah. Looking forward.
Have a good night, everyone. Have a good night, Doctor.
Thank you. You too.
Bye-bye.
Bye.